Imagine a day where everything feels different. A sudden dizziness overwhelms you. Your senses are heightened to the point where even a slight noise is intolerable. And then comes a feeling of despair so deep, it's hard to describe. Panic attacks, sleepless nights, and a sense that something has fundamentally shifted in your body. These are the kind of symptoms that some people experience when discontinuing their antidepressants, especially the serotonergic agents, the SSRIs and SNRIs. This is what SSRI and SNRI withdrawal can feel like. It's a topic that can sometimes be overlooked or sometimes be oversimplified, but the experience is very real for those going through it. And by the end of this video, I'll guide you through not only the neuroscience behind these symptoms, but also help you understand why a broader approach to SSRI withdrawal understanding is needed. And through that, a more personalized approach that can make a real difference to managing withdrawal effectively. So stay with me until the end. It could change the way you think about antidepressant withdrawal. Hi everyone, welcome to Psychiatry Simplified. I'm Dr. Sanil, Rege, consultant psychiatrist, and today we're exploring a critical and often misunderstood aspect of antidepressant use, the SSRI withdrawal syndrome. While SSRIs, also known as selective serotonin reuptake inhibitors, are widely used in the management of depression, anxiety, and some other psychiatric disorders, the process of discontinuing these medications can for some be a distressing experience. Withdrawal symptoms can range from physical sensations like dizziness, nausea, visual disturbances, to emotional symptoms such as severe anxiety, insomnia, irritability, and what some patients describe as an overwhelming sense of despair. The key question we will look at is, why do some individuals find it so difficult to come off these medications, whilst for others, the process may be a lot easier? What is the basis behind these heterogeneous responses? And more importantly, what can be done to manage these symptoms in a tailored, individualized manner? Now, before we go deeper, it's important to recognize that none of what I talk about is to be construed as personalized medical advice. This is general information only, so please speak to your doctor with regards to any individualized advice. So let's get started. First, what are the SSRI withdrawal symptoms? When individuals stop taking SSRIs, they describe a range of physical and psychological symptoms. These symptoms are collectively referred to using the mnemonic Finnish FINISH. F for flu-like symptoms, I for insomnia, N for nausea, I for imbalance, S for sensory disturbances, and H, hyperarousal. The flu-like symptoms include lethargy, fatigue, headaches, and sweating. Insomnia is often coupled with vivid dreams or nightmares. Nausea can sometimes escalate to vomiting. Imbalance manifests as dizziness and lightheadedness. Sensory disturbances might feel like electric shocks or burning sensations. And hyperarousal can lead to anxiety, irritability, and even in some cases, difficulty controlling anger. Why does this happen? Let's look closer at the mechanism behind SSRI withdrawal. So in order to understand the mechanism of SSRI withdrawal, we need to first revisit the mechanism of action of SSRIs. So what SSRIs do is they inhibit SERT, which is the serotonin transporter. This is the presynaptic neuron. This is the postsynaptic neuron. The gap, the cleft in between these two, is known as the synaptic cleft. And the presynaptic neuron usually tends to have inhibitory receptors. And in this case, that inhibitory receptor is the 5-HT1A receptor. When that receptor is activated, the release of serotonin is stopped. There's no serotonin released from the presynaptic end. When the 5-HT1A receptor is blocked, that's when serotonin release from the presynaptic end will occur into the synaptic cleft. So when we think about what SSRIs do, they inhibit SERT, or they block SERT, the serotonin transporter. The serotonin transporter normally would take serotonin from the synaptic cleft into the presynaptic neuron. But by blocking SERT, there is much more serotonin available in the synaptic cleft to act on the postsynaptic neurons. Now, there are 14 different serotonin receptors, and serotonin receptors predominantly act as modulators of many other neurotransmitters. Now, what would happen when the SERT inhibition is removed, i.e. the SSRI is stopped? This SERT would be able to start acting, and because it's able to start acting, it would mop up all of the serotonin that was previously present within the synaptic cleft here, and it would take all of this up again. So therefore, the amount of serotonin that would be available within this cleft would drop. Now, the issue is, how does this link to serotonergic withdrawal? We'll see that the postulated mechanism is that there is a relative deficit within the synaptic cleft, whilst because serotonin has acted on the postsynaptic receptors, for example here, that these receptors have down-regulated. And that's been the postulated mechanism as mentioned in the 2019 Lancet article, but we'll come to this and ask ourselves, is it just about relative deficit and receptor downregulation? The answer may not be as simple. So when we think about the serotonergic complex, we saw that there is the presynaptic neuron, the postsynaptic neuron, the synaptic cleft, and there are 14 different serotonin receptors which modulate a number of other neurotransmitters. If we think about that, thinking simply about the SSRI and the relative deficit in the synaptic cleft versus the downregulation of the other receptors is far too simplistic, because we'll see there's more to the story. SSRIs don't just affect serotonin. They also have other downstream effects on other neurotransmitter systems, particularly noradrenaline. So let's go further into the locus coeruleus and noradrenaline dimension. The locus coeruleus is the principal site for the brain synthesis of noradrenaline. The locus coeruleus is connected to the dorsal raphe nucleus, where serotonin neurons are situated. Thus, the LC, locus coeruleus, and the DRN, dorsal raphe nucleus, which has serotonin, tells us that there is a serotonin-noradrenaline link. What's the importance of this link? These two regions communicate through excitatory alpha-1 adrenoreceptors. Note, these are adrenergic receptors, a discovery that dates back to 1980 by researchers Baraban and Agajanian. The serotonin neurons in the dorsal raphe nucleus send dense projections to the locus coeruleus, exerting an inhibitory effect on noradrenergic neurons. Now, we know that the amygdala has a very high concentration of noradrenergic neurons that originate from the locus coeruleus, and serotonergic receptor activation here tones down the activity of noradrenaline in the locus coeruleus, which is crucial for maintaining emotional stability and arousal. Now, this arousal is described in many ways as anxiety or panic, or in some cases irritability, emotional dysregulation, and there are a range of words for it. But essentially, the principle is that noradrenaline excess, when the amygdala is activated, can result in a range of arousal phenomena. Now, although SSRIs are prescribed in a range of psychiatric conditions, they are also prescribed in other conditions such as depression within the context of menopause, PMDD, in pain syndromes, SNRIs or some SSRIs might be prescribed. So therefore, SSRI prescribing can occur outside the realm of psychiatry, so to say. However, the key neurobiological aspect that has occurred is that when an individual takes an SSRI, there is an inhibitory effect on the locus coeruleus, i.e. there is a certain dampening down of the noradrenaline release. This is, for example, beneficial to reduce hot flushes in menopause. This might be prescribed at low doses in migraine. Some SNRIs are prescribed, helping with the serotonergic effect. In pain syndromes, why? Because a certain component of increased pain i.e. hyperalgesia, is mediated through amygdala noradrenergic activity, which again, serotonergic agents can dampen down. Thus, we can see that the core neurobiology behind serotonergic potentiation is to dampen down the amygdala. SSRIs are also prescribed in cataplexy. Cataplexy is where the individual loses tone in the context of an emotional event, some cases laughter. And this is also mediated by the amygdala. Thus, we can see that these agents are multi-purpose and are used both in psychiatry but also outside psychiatry. So in psychiatry, reduction in noradrenergic activity can help mitigate symptoms of anxiety, hypervigilance, hyperarousal, panic, trauma-related hypervigilance, but it can also dampen down pain, for example. However, when SSRIs are discontinued, this inhibitory effect is removed, leading to a rebound noradrenergic activity, which is one key component that is often overlooked. So in simple terms, SSRIs act like the lid on a shaken soda can, keeping the locus coeruleus neurons that synapse onto the amygdala in check. But when they are either abruptly stopped or in some individuals even as part of a slower tapering, it's like removing that lid. You can get an increase in activity, kind of opening that fizzy can. But besides the increase in noradrenergic activity, there are other physiological changes as well. And one of the important aspects that occurs here is sleep disturbances. We know that SSRIs reduce REM sleep. So therefore, when the inhibitory action is taken away, there is a REM rebound as well. Now, the milieu of restful REM sleep includes a phenomenon known as noradrenergic timeout. So therefore, if there is a noradrenergic rebound, what's happened here is we get a REM rebound through noradrenergic rebound. So the phenomenon of noradrenergic timeout is not occurring. This results in the REM sleep being restless. Now, restless REM sleep itself starts off a cascade of symptoms. You see, REM sleep is a crucial phase for emotional processing and synaptic plasticity. Elevated levels of noradrenaline during REM sleep can lead to nightmares, increased emotional reactivity, and disrupted sleep patterns overall. Now, we know that sleep disturbance or sleep deprivation itself significantly increases noradrenergic activity. So now we've got a perfect storm. We've not only got the possibility of a noradrenergic rebound, we've also got sleep disturbances that are further increasing noradrenergic activity. Now, for those of you who are clinicians, psychiatrists, and other mental health professionals, please check out the Academy by Psych. At the Academy, we have a range of courses that cover the neuroscience and psychopharmacology in detail. Because as clinicians, it becomes really important to link patient symptomatology to phenomenology, and then to the neuroscience or the neurobiology, which then leads to psychopharmacology and then the appropriate choice of medication. The same principles apply when patients present to us with side effects. Hence, it becomes really important to consider the nuances in a lot more detail and become expert psychopharmacological modulators of medications. So for those of you who are interested, please check out academy.psychscene.com. Coming back to the role of noradrenaline and the locus coeruleus, you might ask, Sanil, how do we know that noradrenaline is one of the key players in SSRI withdrawal symptoms? The answer lies in the clinical picture itself, those very symptoms that patients present with. So let me break it down. Using the Finnish mnemonic, in the context of fever, have you ever had significant night sweats or nightmares? Some cases, even a delirium type state. Significant fatigue, shivers. Here, the noradrenergic system is a crucial endogenous modulator of neuroinflammation and plays a significant role in the recruitment of peripheral immune cells to the brain. There is strong evidence supporting the involvement of brain noradrenaline in the genesis of fever. For example, systemic administration of exogenous and endogenous pyrogens, which are fever-causing stimuli, causes rapid activation of noradrenergic terminals in the preoptic region of the brain. Moreover, when brain catecholamines are depleted using certain neurotoxins, the fever response is abolished, emphasizing the critical role of noradrenaline in this process. Now again, for clinicians, this aspect that I've just covered is a key aspect that occurs in neuroinflammatory conditions such as ME/CFS, POTS, and fibromyalgia. To explore these aspects further, check out our curriculum on ME/CFS on the Academy. So that's F. Next, I. Insomnia. I touched on insomnia previously, but patients who have withdrawal symptoms often tend to complain of vivid dreams or nightmares. This is closely related to the REM rebound because of the noradrenergic rebound. The REM milieu, as I mentioned, consists of noradrenergic timeout with elevated levels of dopamine. Third, N, nausea. Nausea too is linked to increased noradrenergic activity. Studies have recorded increased activity in the left amygdala, ventral putamen, and the locus coeruleus during episodes of nausea. Number 4, imbalance. This includes dizziness and vertigo. Another symptom linked to noradrenergic potentiation. Suppression of sensory information processing by locus coeruleus noradrenaline inhibition is suggested to cause drowsiness, a major symptom of vertigo and motion sickness because noradrenaline is involved in vigilance. Then S, sensory disturbances, burning, tingling, or electric shock-like sensations described. These are often the result of hyperexcitability, which is the main pathophysiological mechanism behind these disturbances. We know that pain inhibitory systems descending from the brainstem involve noradrenergic inhibition of spinal nociceptive or pain transmission, highlighting noradrenaline's role in these sensory disruptions. You see, there's a clinical sign known as Lermit's sign, which is described in multiple sclerosis. It is a transient electric shock-like sensation down the spine and extremities caused by neck flexion. Hyperexcitability is considered as the main pathophysiological mechanism for the occurrence of Lermit's sign. And if we look at literature, SSRI withdrawal is also included as part of several other causes associated with Lermit's sign. Now, what's important here is to recognize that Lermit's sign can occur due to a range of causes, one of which includes SSRI withdrawal. And lastly, H, hyperarousal, which includes anxiety, irritability, and agitation, ties directly to amygdala activation, a process that is significantly modulated by noradrenaline. So you can see that the clinical picture, to finish symptoms, strongly suggests that noradrenaline is a key neurotransmitter involved in SSRI withdrawal. Now, besides noradrenaline rebound, with certain antidepressants like paroxetine that have anticholinergic properties, there is not only a noradrenergic rebound, there is also a cholinergic rebound. And this is the reason why a paroxetine withdrawal tends to be a lot more distressing, a lot more significant than many other SSRI withdrawals. It also makes it difficult to come off paroxetine due to that particular reason. Next, let's look at serotonin receptors and the role of the 5-HT1A receptor. We saw that the 5-HT1A receptor at the presynaptic end of the neuron acts as a brake on serotonin release. It regulates the amount of serotonin within the synaptic cleft. It acts as a negative feedback mechanism. This receptor is involved in the inhibitory regulation of serotonin neurons and plays a significant role in emotional and cognitive functions. We have medications such as buspirone. We have SSRIs themselves that modulate the 5-HT1A effect. We have several other agents, both within the antipsychotic realm and the antidepressant realm, that also have 5-HT1A partial agonist properties. So when discussing SSRI withdrawal, an important question arises. Why do some individuals experience significant withdrawal symptoms whilst others do not? What differentiates those who can taper off SSRIs without issue versus those who struggle with severe or protracted withdrawal? To understand this, we must move beyond labels, because thinking about protracted withdrawal or severe withdrawal or discontinuation or withdrawal or relapse doesn't really help us understand the broader construct. Because what we know is that individuals could have both physiological symptoms and emotional symptoms. They could have a combination of both or separate emotional and physiological symptoms. It's also important to recognize that these agents might have been prescribed in a physical condition like pain, but the cessation can result in both a physical rebound and an emotional rebound. So what could be the differentiator? Let's take a closer look at the role of the 5-HT1A receptor. These receptors are important during brain development, but they're also important as they influence brain function into adulthood. Research has shown that 5-HT1A receptor is involved in establishing normal anxiety and depressive-like behaviors during development. A specific polymorphism in the promoter region of the human 5-HT1A receptor, known as C-1019G, is associated with altered receptor expression and may moderate an individual's susceptibility to stress. This suggests that the differences in 5-HT1A receptor function could contribute to why some individuals are more vulnerable to withdrawal symptoms than others. Changes in 5-HT1A receptor function during critical periods can lead to lasting effects both in the development of pathological states, but also in response to therapeutic interventions. Linking this back to SSRI withdrawal, it's possible that individuals with specific 5-HT1A receptor polymorphisms are more prone to withdrawal symptoms due to these early developmental influences. This could also explain why hyperbolic tapering or slow tapering may not work equally for everyone, as those with altered 5-HT1A function might experience more intense or prolonged withdrawal. So a common conundrum when it comes to labels is this withdrawal or is this relapse? You see, these labels create a lot of confusion. When we think neurobiologically, essentially what's happened is there has been a disruption of homeostasis. There has been a change in the homeostatic paradigm, which we call allostatic load, which we'll talk about in just a bit. So therefore, what we've got to recognize is the individual symptoms and then link it to the neurobiological understanding. What we do know is that reduced 5-HT1A receptor binding was associated with the pathology of depression and predicted altered serotonergic neurotransmission in various brain regions. So therefore, what it tells us is that these individuals' sensitivity to any stressor, whether that is environmental stressor, the onset of depression, or an allostatic load such as a withdrawal process, all of it could result in an exaggerated response that is now presenting as the withdrawal syndrome. See, I mentioned earlier that hyperexcitability seems to be a core component of withdrawal. The most common symptoms tend to be electric shock-like sensations. How does this link? You see, the 5-HT1A receptor, along with the 5-HT2A receptor, plays a crucial role in neuronal excitability. And this has been implicated in epilepsy. Epilepsy is a significant manifestation of neuronal excitability, where processes of kindling and sensitization are occurring. Specifically, 5-HT1A binding is known to reduce seizure activity. In other words, if we take out withdrawal or depression or relapse, if we simply ask the question, can individuals with pre-existing 5-HT1A receptor abnormalities have a greater propensity for neuronal excitability? The evidence suggests that the answer is yes. So what this tells us is that SSRI withdrawal isn't just about the medication. It's about the individual characteristics as well. This does not mean that the effect of SSRIs are to be neglected. What it means is that we need to look at the pharmacology within the context of the individual presentation and their characteristics, which is the basis of an individualized approach to patient care. Next, let's look at the contradictions in evidence when it comes to the 5-HT rebound debate. You see, when discussing the mechanism of SSRI withdrawal, I mentioned that in Lancet 2019, what was stated was SSRI withdrawal has been attributed to a relative deficiency of serotonin in the context of widespread adaptation of serotonergic receptors. But a study in 2024 said, and note, this is an animal study which had a short duration of exposure to paroxetine in mice. We report that SSRI discontinuation is associated with a rebound increase of 5-HT function that lasts many days. We speculate that this effect is linked to a rapid fall in extracellular 5-HT following abrupt cessation of SSRI administration, leading to disinhibition of 5-HT neurons via removal of inhibitory 5-HT feedback. This removal of 5-HT inhibitory feedback is essentially the 5-HT1A inhibitory feedback. This response to SSRI discontinuation resembles the changes of other neural systems following cessation of treatment with other psychotropic drugs, suggesting a common neurobiological mechanism. So with these two contrasting aspects, one talking about a relative deficit of serotonin, whilst the other talking about a 5-HT rebound, and considering the noradrenergic rebound that we spoke about, along with the 5-HT1A receptor abnormalities, we've got to think about the withdrawal syndrome in a much broader light. And we need to do this because if we simply reduce SSRI withdrawal to hyperbolic tapering, we'll see that there may be adverse effects or disadvantages to that approach. Yes, hyperbolic tapering is one strategy, but is it for all? And that's the question we'll answer now. In order to understand what's happening in the brain, we've got to get back to the principles of allostatic load and understand sensitization and desensitization cycles. You see, the process of withdrawal is an allostatic load. Essentially, any stressor triggers off a response from the brain and the body to set into motion processes that will turn the allostatic load, reduce it to get back to homeostatic paradigms. So we want allostasis to then move towards homeostasis. However, chronic stress changes this paradigm, makes it more difficult to get to homeostasis. So let's look at the allostatic load model within the CREAM model, which is the anti-reward and reward deficit model. And let's see how allostatic load disrupts the process and can set up a cascade towards this really significant sensitization and desensitization cycle, making it very difficult for individuals to move out of it. So as we can see here, this CREAM model has been described in pain medicine. Now, when we think about pain, pain can be physical pain or psychological pain. And we can see within the context of SSRI withdrawal, we're noticing both. There is physical and psychological pain occurring, or physical and emotional allostatic load. So if we think about a normal state, we can see there's reward and aversion in equilibrium. That's the balance that we want to achieve. When the initial process begins, we can see that there is a pain load occurring. This pain load is acting like an allostatic load, trying to disrupt the stability. But at the same time, there is a pain opponent. In this case, it's analgesia. Within the context of SSRI withdrawal, one might be trying to oppose that pain through other techniques. Now, in some individuals, they move towards an adaptive state, pain to pain relief, and they move up towards the homeostatic paradigm again. But in some individuals, the pain load continues. The chronic stress continues. And here what happens, chronic stress recruits a number of other neurotransmitters. And this has been described, this is part of the courses that we have. This is the pathophysiology in the range of neuroinflammatory disorders that I mentioned. We've covered this in the MECFS curriculum, but we've also covered this in the neuroscience of addiction. As in addiction, this phenomenon also occurs. So what we can see here is as the pain load continues to increase, the analgesic opponent is struggling. This is the allostatic load and the spiraling distress that occurs. Now, as I mentioned, the chronic stress, so the chronic allostatic load, recruits a number of neurotransmitters. Here there's dopaminergic trafficking, Noradrenergic trafficking, increased levels of CRF, which releases cortisol, and as it goes further, there is glutamatergic dysregulation, and glutamatergic dysregulation leads to a phenomenon of salience, which means that the individual moves towards a very narrow way of living, where those symptoms become a lot more all-consuming, and the glutamatergic activity creates a behavioral activity that narrows down the individual's life. And we know in severe or protracted withdrawal, this is the phenomenon occurring. The important thing to recognize here is that the analgesic opponent that's being used, for example, in SSRI withdrawal, may be hyperbolic tapering, but this hyperbolic tapering may actually be contributing partly in some individuals to this allostatic load, as we'll see in just a bit, or may not be sufficient. And this results in an ongoing increase in stress, which is known as the anti-reward state, along with a reward deficit state, where individuals have anhedonia, amotivation, while the anti-reward state is elevated levels of fear, anxiety, increased salience network activity, some cases pain, etc. So it's sensitization of the stress systems along with a desensitization of the reward pathways. So we can see what's happening here based on the opponent process theory, OPT. Synergism may occur when the recursive, partly shared positive feedback CREAM loops are produced both by chronic pain and potentially by the analgesics themselves. In this case, think about chronic pain as the withdrawal process and the analgesic as the hyperbolic tapering process, resulting in a spiraling distress cycle where there is an amplification of the aversive physical and emotional aspects of the pain. Note here, the pain may be emotional and or psychological. Such processes may further contribute to chronic pain, treatment resistance. This pain is a broad concept. So this is one of the core processes in allostatic load, physical pain or psychological pain. So if we think about it, can individuals who've experienced significant stresses previously, maybe trauma, may have predisposing medical conditions which creates a vulnerability towards this allostatic load, or exposure to other medications, a pre-existing severe depressive illness? Could these individuals struggle to reach homeostasis when presented with an allostatic load? The probability is yes. And this is what leads to differences in responses when it comes to withdrawal. Let's look at how this presents in the context of a clinical scenario. So let's look at this hypothetical scenario. A 42-year-old female who presents after discontinuing her long-term antidepressant use. She says, physically, it's been a nightmare. I've had nausea, constant dizziness, and this strange dizzy sensation in my head. There's been a dull but constant headache, tingling in my face, and my tolerance for noise, it's gone. Loud sounds, music, even small things like sweaty hands or feet, they all overwhelm me. I've lost over 9 kilograms because my appetites disappeared completely. Note here that what one can find is a range of arousal symptoms. As a clinician, I'm not necessarily trying to box this into just withdrawal or just relapse. What I'm looking to understand is what are the neurobiological aspects to this presentation. We can see that there are some physiological aspects, but there are also some emotional aspects, and that's to be expected. This is of course occurring in the context of discontinuation, but I know that the discontinuation of the antidepressant has resulted in an increase in amygdala activation, because that's what happens when the SSRIs are taken out. Now, the amygdala mediates all kinds of responses, emotional responses, physical pain responses. It is also the driver towards reward. It mediates anxiety, but it also controls the autonomic nervous system, so it can give a range of bodily symptoms. It's not for us to decide how the amygdala is going to react in the context of a stressor. Emotionally, it's been unlike anything I've felt before. This overwhelming sense of sadness, a pit of despair that's unshakable. I've lost interest in everything, even the things I used to love. I get these random intense bouts of anxiety for no reason, panic attacks too, something I'd never had before. I feel like I'm losing control, like I'll never recover, and that thought terrifies me. I'd like to point out here that two things are happening. There is the sensitization of the stress systems due to the allostatic load. This is part of the rebound. The arousal systems have rebounded, but note, there is also the reward deficit state occurring in the form of lost interest in everything, the sense of sadness. And this is the reward deficit anti-reward state that is occurring. And in the context of sensitization, what tends to happen is even minor stresses create an exaggerated response. That is the phenomenon of hyperexcitability or sensitization. Stress is unbearable now. It makes me overly emotional and hypersensitive to the smallest things. Sleep, I barely get any. This is one of the key aspects to take into account because not only is it part of a noradrenergic rebound, very likely, but we know sleep deprivation will significantly increase noradrenergic levels. Along with that increase in noradrenergic levels due to sleep deprivation, we will also have noradrenergic trafficking due to chronic stress. So you can see the cascade being set up. My mood shifts so fast it's confusing, and all of this feels new. The intensity is just nothing like I've ever known. Now here, let's imagine the patient wants relief. So they think that I need to get back on the medication. Now these phenomena can also occur in individuals that are tapering, including hyperbolic tapering. They're reducing the medication, but they're having a range of symptoms and are not quite sure what's going on. That itself is an allostatic stress. Therefore, they still have the process of sensitization and a reward deficit state occurring. So let's say at this point, as part of both the hyperbolic tapering and or a person who's discontinued, they increase the dose to the previous level. Now, an increase in the dose in the context of a process of allostatic disruption acts as an allostatic load. Now, in some individuals, that's fine. It reduces the symptoms, which indicates that the homeostatic paradigm is reached at that level. But in others, things can continue to get worse. And this is because the process of increasing the dose or bringing back the agent itself can act as an allostatic load, increasing sensitization. And this happens with SSRIs because in the initial stages of SSRI prescribing, there is an increase in anxiety and arousal, and therefore it can add a little bit of fuel to that fire, and that's the issue in some individuals. You see, in that scenario that we saw, they're unable to sleep, they have agitation, they have hyperexcitability. So here, introducing an SSRI is not really acting as a substitute anymore. Here, it's being introduced in the context of agitation, when we know that SSRI introduction or increased doses in the context of agitation will worsen it. So we're looking at a different phenomenon that requires a different approach. So, in the context of reintroduction of the medication, the patient expresses extreme distress. That day, everything spun out of control. Within hours, I was wound up, completely unable to eat or sleep. My tinnitus got much louder. I was pacing back and forth, not knowing what to do with myself. It was one of the most frightening experiences of my life, and I'll never forget it. I assume it was the drug flooding my system again. This is a description of agitation, a significant dopaminergic noradrenergic trafficking that is occurring due to allostatic load mediated by the amygdala. This is no longer just within the withdrawal paradigm where we can continue to simply reduce slowly or increase doses. We've got to think about all of the other aspects that are occurring. So therefore, is hyperbolic tapering for everyone? And is hyperbolic tapering the only method to consider when it comes to SSRI discontinuation? And if you think about everything that we've gone through, you probably know the answer. It is one strategy within a broader paradigm. I've covered hyperbolic tapering in this video here, so please do check that one out. To summarize hyperbolic tapering, the aim is to minimize withdrawal symptoms by giving the brain more time to adjust to those lower levels of serotonin. Remember, the principle of hyperbolic tapering is based on the idea that there is a relative deficit of serotonin in the context of down-regulated serotonin receptors. But we saw in the recent study that withdrawal symptoms may be contributed through a 5-HT rebound. So we've got to ask the question, can hyperbolic tapering worsen the situation in some individuals? And the answer, thinking about the overall paradigm, is yes. Why? Because of the following reasons. One, extended allostatic load. Prolonging tapering could maintain the brain in a state of allostatic stress, potentially exacerbating or lengthening the duration of withdrawal symptoms. Two, heightened sensitization. Gradual dose reductions without thinking of the broader systems may increase the sensitivity of the serotonergic system, of course other neurotransmitters as well, such as noradrenaline, corticotropin releasing factor, dopamine, thereby elevating the likelihood of a withdrawal or relapse. Three, there may be a risk of persistent symptoms because prolonging tapering might inhibit the re-establishing of the homeostatic paradigm or equilibrium as we saw, resulting in chronic neuropsychiatric symptoms. Fourth, there might be a risk of relapse of the original illness. Continuous exposure to withdrawal symptoms, even if mild, could amplify psychological stresses leading to heightened anxiety and relapse risk. And fifth, there may be a risk of symptom misattribution because frequent fluctuations in symptoms during tapering may lead to misinterpretation of normal physiological changes as part of the homeostatic paradigm. But this misinterpretation could happen due to the heightened anxiety state. We know that in the context of hyperarousal, in the context of anxiety, misinterpretation of stimuli can occur. So therefore, some of these normal physiological changes could be misattributed as pathological, potentially reinforcing a cycle of anxiety. So the key aspect to recognize is that whilst hyperbolic tapering is a useful strategy and is to be considered in many individuals, and the principle is helpful when we consider discontinuation of SSRIs or SNRIs, it's important to recognize when it might not be sufficient on its own one, or when it might be contributing to worsening, in which case we have to consider other interventions to reduce the other neurotransmitter potentiation, such as noradrenergic potentiation, to manage the overall picture. So how do we look at this broader paradigm? I won't cover hyperbolic tapering here because you can see that in more detail in this video here. What are the strategies that we use to manage the other aspects, such as the allostatic load, the noradrenergic rebound, the dopaminergic trafficking that can lead to significant agitation, and the hyperexcitability? Firstly, there's no one-size-fits-all approach. Secondly, it's an extremely individualized approach. So therefore, what I'm going to talk about now is, of course, general information only. The plan has to be implemented through a discussion with your doctor. The first most important aspect to consider in the context of reduction of medication, discontinuation, is the focus on sleep. Because sleep is one of the best predictors of a homeostatic paradigm. If individuals are sleeping well, that tells me that the overall milieu in which the prefrontal cortex and the stress systems are operating is overall a homeostatic paradigm. So it's really crucial to look at sleep, and if that is disturbed significantly, it's important to intervene early. Second, recognition of vivid dreams and nightmares, which indicate a REM and noradrenergic rebound, can be addressed through alpha-1 antagonists or alpha-2 presynaptic agonists such as clonidine. Alpha-1 antagonists include prazosin. You can learn more about clonidine in this video here. For clinicians, of course, we cover clonidine, guanfacine, prazosin, and a range of other mood stabilizers in our psychopharmacology courses on academy.psychscene.com. So please do check that one out. You see, clonidine is an agent that's used in alcohol withdrawal, in opioid withdrawal, because opioid withdrawal, alcohol withdrawal also has significant noradrenergic rebound activity. In fact, most allostatic load tends to have significant noradrenergic potentiation. And if that continues, that's when the cascade moves towards significant sensitization and the reward deficit state. Second, in some individuals, if the process is continued where the individuals are having hyperexcitability, here certain anticonvulsant mood stabilizers that reduce glutamatergic overactivity can be considered, because as I mentioned, as part of the CREAM model, glutamatergic excitation is one of the core processes. Here, agents such as long-acting benzodiazepines or lamotrigine can be very, very helpful. If there is significant agitation, which is the top end of the aberrant salience or mesolimbic activation, low-dose antipsychotic medications may be needed to address the significant agitation, to reduce the overall allostatic load. And this principle is also applied in pain medicine, where D2 antagonists are considered as part of the D2-5-HT2A antagonists, atypical antipsychotics, to reduce this heightened agitated state. These are just some of the strategies. Note that what I've mentioned is to be considered or to be thought about when individuals are struggling or worsening significantly with the process of tapering. The foundation, as we've known for a very, very long time with antidepressants, is gradual reduction and discontinuation. However, we know that yes, this has probably not been done as well as it should have, but we know better. But at the same time, we also need to recognize that hyperbolic tapering or just focusing on gradual tapering is not the answer in some individuals. So to summarize, hyperbolic tapering can be an effective strategy, but it's important to monitor for signs of sensitization and prolonged allostatic load. If symptoms worsen during tapering, it may be necessary to adjust the tapering schedule or incorporate additional treatments to manage the neurobiological changes that might be occurring. So, SSRI withdrawal syndrome is a complex and multifaceted condition that goes beyond the simple dichotomy of withdrawal versus relapse, gradual tapering versus hyperbolic tapering. It involves intricate neurobiological processes, including noradrenaline rebound, serotonin receptor dynamics, and the impact on sleep and emotional regulation. It also includes processes that we see in pain medicine and in the overall allostatic load paradigm in neuroinflammation. Remember, the key is to move beyond labels and focus on the underlying neurobiology that drives the symptoms, getting back to first principles. So I hope that you found this video helpful. If you liked the video, don't forget to leave us a like and subscribe to our channel to keep in touch with all our future videos. If you've got any comments, don't forget to leave them in the comment section below. And a big thank you to all of you for supporting this channel. We appreciate your support. I look forward to seeing you in another video soon. Until then, stay curious. Bye-bye.